A Deuk Laser Disc Repair, anterior cervical, transdiscal, endoscopic, annular debridement, and removal of the herniation at C6-7. Now we've already placed our needle percutaneously to start the surgery, and I'm going to go ahead and have Diego show you the MRI of this patient without showing her name, obviously, and we keep all of our patients' identity strictly confidential, but we do like to live stream surgery so people can ask questions and learn while they're watching the surgery. So we're broadcasting on 8/3/21, August 3rd, 2021. This is our second surgery for the day. And this patient has a large herniated disc at C6-7 on both sides, so we're going to clean up both foramen and remove the herniations. Now let's go ahead and get a fluoro shot. You've had an opportunity, Diego, to show the MRI with the herniated disc and the arrow pointing to it?
Yes.
And the patient's symptoms, of course, neck pain, headaches, and arm pain, weakness, numbness. Can you hold her head in
Let me know when you're ready.
inline traction? Tell me once you've got her. Good. And pull the shoulders a little bit. And let's get a shot. All right, so I need to see C2. I need you just quarter inch north, quarter inch. That's too much shot? All right, perfect. So we got 2, 3, 4, 5, 6, 7. Let's get an AP. Everyone in agreement, relax. We are at C6-7, relax everyone. So to get down to C6-7 on a patient with a shorter neck, like some of our patients have, we need to pull the shoulders. And you can see the needle is in excellent position. You're fine, you're fine. We're just past the front of the disc and into, with the tip of the needle, into the left side, which is pretty standard. All right, we're going to go ahead and do our discogram. Keep your fluoro there. And let's do a quick discogram at C6-7. I'm happy with our position of the needle. Now I'm going to go ahead and inject a little bit of dye. This is some Omnipaque, right? Shot. All right, so shot. The Omnipaque is what, 50%? You can see the dye is leaking out of the disc on both sides and going around the nerve root. So there's a tear in the back of the C6-7 disc on the right and left side. It's a broad-based tear. The dye is leaking out through the back. And you can see it exiting the back of the disc into the foramen. Let's try one more shot. All right, very nice. You can see it wrapping around the nerve root. That's actually the C7 nerve root on both sides. Okay, let's go to a lateral view and get a quick shot. I'll need shoulder pulled and I'll need a head inline traction. Let's start with our anesthesiologist, inline traction. And then let's do our shoulder pull on the count of 3. 1, 2, 3, shot. All right, let's try again. Try to get a little lower. All right, well, that's the best we're gonna do, unfortunately. All right, relax everybody. So, we've done our discogram. Her shoulders are broad and her neck is deep. So it's hard to visualize her, okay? That said, I like to place my guide wire. I will need another shoulder pull. And this is not for localization at this point. This is just for, actually not for localization of levels, but localization of my instruments at the back of her disc. Shot. All right, we need a better lateral. You need to come further south and get better penetration. I would close up your gate. There. That's pretty good. I could live with that. Keep it there. Shot. All right, that's good. Relax. Let's go ahead and do our injection and our incision. So we've lost basically maybe 1 drop of blood so far. This is the Deuk Laser Disc Repair procedure you're watching. You won't find this done anywhere else. It's done at Duke Spine Institute. We're the pioneers of the procedure. It's a type of endoscopic surgery, okay? And just like there are many types of fusion surgery, or there's different types of artificial disc surgery, there's also different types of endoscopic spine surgery. And the type of endoscopic spine surgery we do here is unique. We do things that other doctors don't know how to do or don't do. And we do it because we found that we're able to cure the actual pain the patient's having in their neck or back pain, neck pain, if we do a debridement of the annulus, if we do this procedure properly. Everything okay, guys? I'm making a 4mm incision, and with 4mm incision I'm going to do the entire surgery. So I'm leaving my guide wire, and I need to take this out. I need Luis pulling the shoulder,
Doctor?
not too hard. And Doc, I need you inline traction again.
Okay.
You good?
And Jordan, you ready? Go ahead. I need a better view. You need to come further south. You guys have moved the body south by pulling. So, shot. I need better penetration. That's better. That's good right there. Shot. Yep. Give me just another few seconds and we'll be all right. All right, at this point I'm going to bring the dilator down, the guide wire, and I'm going to dock it, the tip of this thing on the front of the spine. Shot. Got to make sure the guide wire doesn't move. You can see the dye in the spinal canal shot. That's nice. Almost done, folks. Shot. We're docked at the front of the spine now. Actually into the spine. Shot. All right, let me have an AP just to make sure this thing hasn't moved. Coker. Wait. You're too close there. Wait. Wait. Can you move away a little further? No, no. Up. Good. Alrighty then. Let's get a picture. Let's try to get that in the middle. Nice. This is a nice, take your time, get it right picture. So I want all the spinous processes lined up with the pedicles to the side. To me, that looks pretty darn good. Right? Anybody have a problem with that? Luis, shot?
I like it.
You can see the guide wire coming out the end there. All right, so I'm happy with the AP view. Let's go back to the lateral view. Now, this is the part that's going to suck for you guys, because I need a good cranial pull, shoulder. I'll help you on this side. Should Luis get in here?
Yes, sir.
Okay. Just give me, I'll get one side, you get one. Okay. Just push in and down. Shot. All right, not bad. Not bad at all. That's really nice. Okay, so let's go ahead and we're going to advance this a little more. Pretty big tear in the front of the disc. Shot. Yeah. I can feel it just going. There's a pretty big tear in the front of the disc. So I didn't even have to, you know, hammer it in. Let's go. Shot. All right, yeah, we're almost to the back. Once again, this is a very damaged disc. Hold on, hold on. Shot. Yeah, almost there. All right, let me have the other tube. So we got our dilator in. We're going to bring our metal coffee straw, McDonald's coffee straw in. And I'm going to twist it down. Any questions from our audience so far?
No, sir.
Let's get a shot. That's perfect. The tip of the dilator is perfect. The tubular retractor is sitting on the front of the spine now. So now I gotta advance this tube over the dilator, through the disc, to the back of the disc. And at the same time, hope this dilator doesn't back out or go forward. And we're gonna have to watch that carefully. Okay, so Shot. Uh-huh. It's going. Shot. And you're pulsing, right?
Yes.
All right, so our dilator moved back a little bit. We don't want that. Shot. All right, that's good. Shot. Yeah. Shot. All right, so that's about as far back as we want it to go. Let's see where we are. Shot. That's about as good as it's going to get right there. Maybe a small amount more. Shot. That's perfect. Okay. Well, I don't know how we did it, but we got kind of lucky on this one because it's really hard to see at C6-7 on the X-ray. I'm sorry?
Can we just get another pulse?
Yeah. Shot. Perfect. All right. So you can see from that lateral view, we're in right at where the tear begins in the back of the disc that we're trying to fix. And you can actually see a line of contrast. Watch behind you, Luis. In the spinal canal along the dura of the spinal cord, behind the vertebral bodies. That's from the dye that I injected. Can you see over here? Eye in the sky. Diego?
Yes.
So the patient's laying on her back. She's looking up at the sky. This is her face where my hand is, my left hand. This is the chest. Her neck is there. We're on the right side of her neck. And we're going to fix the herniation on both sides because she has symptoms in both arms. So we're going to take care of both sides. You know, her right arm is worse at times. Her left arm is worse at other times. So we're just going to fix both sides. She's lost basically 1 drop of blood. That's it right there for the whole surgery. A drop of blood. How's our blood pressure? Okay. Let me have one of those. Oh, I don't want to do that. So I'm going to, as Luis was doing earlier, we're going to wrap this gently around so that we can direct the irrigation into the bag, hopefully. Okay. Now we're going to use our scope. Everyone see the scope? You see this, Diego?
Yes.
We've got an endoscope that goes down. We've got a laser, irrigation, light, and suction here on the tube, and then the camera. All right. We're going to head down the rabbit's hole to the herniation. Now this patient has a C6-7 herniated disc, as you can see on the MRI. And at the bottom of this metal tube is the beginning of the annular tear and the disc herniation. Okay? Yep. Take your time. Let me know when you're ready.
You want to bite some? Or?
Huh?
You want to bite?
I had some pizza for lunch. Thank you, though.
No.
Thank you. I try to be funny when I can be. So if you're a new watcher of the Deuk Spine Institute's live videos, we stream the entire surgery. We do not edit these surgeries. We just show you the whole thing. So if we have a problem during surgery, you're going to see that problem along with me at the same time that I see it. And you're going to see how we deal with it. So why is that helpful? It's helpful because if I edit all my surgeries and took out the problem areas, then when somebody tries to learn how to do the surgery, they're basically not going to learn how to deal with the problems because we never showed the problems. So I think it's an important part of education in medicine to not just see how the good is, but also how the bad can be. Yeah, let me grab some out. So we want to show good and bad so that it prepares the student or resident, whoever is learning, how to deal with, obviously to do the procedure properly, but also to deal with problems as they arise. We rarely have problems with the laser surgery. That's because it's pretty straightforward. It doesn't involve screws and rods. There's no metal, no fusion, no artificial metal discs or plastic discs. It's all natural. The surgery is completely natural, and all we're doing is going to the back of this herniated disc and doing what is the least invasive treatment, which is to treat the herniation itself at the level of the annular tear. Now, most doctors don't understand the importance of the annular tear and how important it is in the pathophysiology of herniated disc symptoms and disease. But we discovered this at Duke Spine Institute, that the annular tear is the most important part of a herniated disc. It's not the herniation like everyone talks about. It's the annular tear that's the most important part, because it's the tear that actually is responsible for all of the symptoms from most herniated discs, about 95% of them. It's not actually pressure on the nerve root, it's irritation of the nerve root. And that irritation on the nerve root comes from inflammation of the nerve root, and that inflammation of the nerve root comes from the annular tear and the interposed nucleus. These are all pieces of herniation here that I'm dealing with. Let me try to grab them out. When you get a big piece like that of herniation, rather than trying to zap it all away with a laser, which takes a while, you just want to try to go in there and grab them out. It's a lot safer, it's more efficient use of time. And to do that, I use a metal grabber, a little metal grabber. It's designed for this type of surgery. Endoscopically, it's called a pituitary rongeur. Okay? And it looks like any other pituitary rongeur in medicine, except that it's very long and skinny. Hey, you want to show it to them? Get the light on.
Lights on, please.
Take a look at this, Diego. All right, can you see this thing?
Yes.
So it's super long and skinny. It's about 12 inches long, and I put it down this tube, and believe it or not, it takes a lot of practice. Look at that, Diego. Look at this herniation that just came out. You see it?
Yes, I do.
All right, you got a good view of it. It's blue because it's degenerated nucleus pulposus. And I grabbed it out with my little grabber, my little friend. Say hello to my little friend.
Thank you very much. I appreciate it, buddy.
My little friend is a good little friend.
Lights off, please. Thank you.
There's more herniations right there coming out.
We have a question.
Yeah, of course.
Can stem cell repair annular tear?
Can stem cell repair an annular tear? No. No, it cannot. The only way to repair an annular tear is one treatment in the world. It is the one you're watching right now. This surgery was designed to repair the annular tear with a laser. It's the very best in the world. There's no other way to repair an annular tear. You can fuse a disc, and maybe you'll get rid of the symptoms of the annular tear. But in general, to fix an annular tear, you have to go in and remove the jelly that's sitting inside the tear. That's the nucleus pulposus that I'm doing right now. And after you remove that jelly, you have to let the disc heal on its own, naturally. You have to clean the annulus. Sorry, you have to debride the annulus, and then you let it heal on its own naturally. Okay? This is all part of the herniation, all of this. Incredible. Some of it's newer. Can you give me the age of our patient? All right, she's in her 50s. Okay? And you can never tell how old somebody is by the inside of their disc, but you can tell how old their injury is from the inside of the disc with endoscopic surgery. I can tell if it's a newer injury or an older injury. I got to flip it. So this is, to me, so far what I'm seeing, a newer injury. Anybody know when her pain started? When did her pain start? Anybody know? Roughly. So a lot of people with herniated discs end up having episodes of pain that get worse over time. So there's a piece of herniation. They may have had an initial herniation, then got better, and then it happened again where they injured the disc again and they have more inflammation in the disc as a result of the re-injury. So March. She injured this in March. This looks like about a 3-month-old injury because we're not getting a lot of scar tissue yet. We're not getting a lot of collagenization. We just got chunkies that are coming out. You see those chunks? Hit rewind. Those chunks are the herniated fragments. They've gone through the posterior longitudinal ligament right there. You can see the end plate of C6 right there. You see that ridge? That is the back of the vertebral body of C6. So pretty amazing. We're seeing all of this back there. And this is a piece of herniation right here. And there is a little bit of calcification there to the right that indicates that this does have some age to it, because the calcification only happens when you have time, a lot of time. So this could be a re-injury. This is a fresh herniation. You see that right there that I'm taking out? That's a fresh herniation. That's not an old herniation. So I think she had an initial injury perhaps some time ago, but then it kind of partially healed and she was asymptomatic, minimal symptoms or asymptomatic, and then she re-injured it back in March and really blew it out in March. So we're fixing all that. This is the older part right here, like older than March part. So all the very bright blue fragments of herniation are the newer fragments. Oh yeah, and she did say to me in pre-op that her symptoms keep getting worse. They keep changing arms. So clearly she keeps re-injuring this disc. So it's not like it's a one and done. It's a multiple injury. There's a big piece of herniation there. Very typical of herniated disc. If you talk to people with neck pain or back pain, they'll tell you it gets worse at times, then gets better, then gets worse, then gets better. And that's the disc trying to heal. When it gets better, it starts to really heal. It forms a membrane. And that membrane is a membrane made out of scar tissue. So they get a little bit of healing, and then they re-injure it again, and the pain comes back with inflammation from the re-injury. It's just like your knee, you know? Whoa, yeah, we got a swimming pool. It's just like your knee, right? If you have an injury to your knee and you rest it for a while, the inflammation goes down, the pain subsides, and you feel better for a while. And then you go out and play, you know, sports again, and you re-injure it because it really didn't heal all the way. It healed partially. And so that's what we're dealing with, folks. We're dealing with a type of injury, a pattern of injury where the patient is repetitively re-injuring themselves. Oh, so aggravating, huh? That we're having a pool of water. Okay, it's fine. So I'm going back and forth, left to right, and removing all these little herniation fragments. What's this here? What's that? We need some help with managing some of these tubes and cables. We're just about done. Look at all the scar tissue right there. Again, that's the end plate of C7 right there. So that's a superior end plate at 3 o'clock of C7, and that's the back of it. And this is all scarred up posterior longitudinal ligament. You can see it's all scarred up from inflammation. I have less than 5 minutes, Doc. So I really want you to work on getting them switched over to propofol, and just that way we can wake them up quick and they're not sitting there under gas for so long. Yeah, 1 levels are quick, 15 minutes maximum. All right, gonna come back to my side one more time, and we'll be done. So this surgery This patient, if they chose a fusion, would have to have their neck filleted open. They would have literally a metal plate or an artificial disc. And I don't like artificial discs because I'm going to tell you the truth about them. They do pop out and they do cause problems for people. Okay? Unlike the people that are selling them to you that need to make money selling them, I don't need to make money selling artificial discs. Okay? I don't get any money selling artificial discs. I don't make any money on them. So I'm going to tell you the truth about them. They're totally unnatural, and there's a lot of problems related to them, okay? Including fusion, autofusion. Lots of people with artificial discs their spines end up fusing themselves. Of course, that's not the intention, but it happens. Just look it up on the internet. You'll find lots and lots of cases of autofusion where the artificial disc fused itself. We're pretty much done. There's a little piece there. We'll float that out, and I think we're pretty much done now. Just want to make sure going back and forth looks good. Okay, we're done. So let's suck this light on. I'm going to suck the juice out. Let's go ahead and get the betadine in. And give that a minute to work. I'll take a question. Do you have any questions from our audience?
No.
Okay.
Yeah, please. Document obviously the malware and
So let me show you all what we did here in just a moment. This was a one single level of herniation, okay? And because it was one level, we just had to go into one disc and fix one disc. The rest of this patient's discs look good. Nothing wrong with them. Okay? So, scope is still on, guys. We need the scope off. So this patient would have had to have a big incision on their neck. Let me show you what I'm talking about. Okay? I got it. Can you see here? Can you see here? Diego, talking to you.
Yes.
All right. So they would have had to have an incision like this on their neck for a fusion. And look at this tiny incision we made. 4 millimeters, it's nothing. And their entire surgery was done through this tiny little incision. I'm going to show it to you in just a minute. But this is the future of spine surgery right here. It's called the Deuk Laser Disc Repair. It was pioneered here at Duke Spine Institute. It's a type of endoscopic spine surgery. And rather than just going after herniations, we go after the tear that is the source of the herniation that allowed the herniation to come out. It's the tear that's the actual source of back pain or neck pain. It's the tear that's the source of headaches in the case of a cervical disc herniation when people have headaches. And then it's also the tear that's the source of the arm symptoms like tingling, numbness, weakness, and pain shooting down the arm. For the last hundreds of years, doctors have been wrong about the cause of patients' pain. Number one, they think that they don't know what causes it, but we know what causes the pain. It's the actual annular tear. They also have not known why people have radiculopathy, which is pinched nerve symptoms or irritated nerve symptoms. The reason is irritation, not pinching. But they're all looking for pinched nerves on the MRI, and they're not finding them, which is why they're turning patients away and saying there's nothing that can be done. In reality, we can fix that. 95% of patients with neck pain, arm pain, are being turned away by doctors for surgery or not even referred because the doctors don't know what to do to fix the problem. They don't know how to fix it. They don't know the source of the problem, and they don't have a solution. So that's why we broadcast so you can see we're able to fix these problems now. All right, we've lost literally 1 drop of blood. If there are 20 drops of blood in 1 milliliter, then, and there may be 20, then we've lost literally 5% of 1 milliliter. So we'll just call it half a mil. because those numbers are too small. This whole surgery was done basically with no blood loss. Okay, we're gonna get her awake soon. Do your best. Yeah, the next one will be short too. Once we get in and get started with the laser, you could turn off the gas for a 1 level. All right, can you all see the neck here?
Yes.
So there it is. There's the incision. See it? 4 millimeters. Tiny. We're going to put a Band-Aid and we'll get her extubated and out of here. Great job, everyone. Any questions?
No.
All right, audience, go ahead and type up questions for us. We'll be happy to answer them for you live. Again, this is Dr. Deuk Majin. We're at the Duke Spine Institute here near Orlando, Florida. We're located on the Space Coast. And you have just watched a live spine surgery on August 3rd, 2021, streamed uninterrupted and unedited for the purposes of education. And we take questions, so go ahead and type them up. Our next case will be another single level Deuk Laser Disc Repair.
If you have the means to do this, you should do it because it's life-changing. Thank you.
You're welcome. I'll see you out there on the go-kart track. You want to say to the rest of the world before we wrap this interview up?
If you're thinking about it, come see Dr. Deuk. I've been telling everybody, come see Dr. Deuk. You changed my life. So happy for you.
Take care.
So,
This guy's the man. Come see him.
Oh, thank you very much. Take care. Anything else you want to say to the audience before you get out of here and go home?
It's a good place to come and get answers.
Absolutely.
Anything you want to say?
He's worked on both of us, and we can't say enough to thank him enough for his expertise and willingness to do things that other doctors would not do, wouldn't take even the risk at doing. He's able to do that is beyond our comprehension, and we are very grateful and thankful for Dr. Deuk.
Duke Spine Institute is grateful for both of you, so thank you.
Thank you.
You're welcome.
If you have the means to do this, you should do it because it's life-changing.
see you out there on the go-kart track.
You want to say to the rest of the world before we wrap this interview up?
If you're thinking about it, come see Dr. Duke. I've been telling everybody, come see Dr. Duke. You changed my life. I'm so happy for you.
Take care.
This guy's the man. Come see him.
No, thank you very much.
Take care. Anything else you want to say to the audience before you get out of here and go home?
It's a good place to come and get answers.
Absolutely.
Anything you want to say?
He's worked on both of us, and we can't say enough to thank him enough for his expertise and willingness to do things that other doctors would not do, wouldn't take even the risk at doing. He's able to do that is beyond our comprehension, and we are very grateful and thankful for Dr. Duke.
Duke Spine Institute is grateful for both of you. So thank you.
Thank you.
You're welcome. Any questions?
One. Perfect. Cool. All right. Did you run a video?
And yes, the video is.
You can keep running it until it's done if you want. I don't want to wait.
Okay. There you go.
Just whenever you're ready to give me a countdown. Yep.
All right. And 3, 2, 1.
Hello everyone, I'm Dr. Duke Machen, and we have just wrapped up another surgery here at Duke Spine Institute. The patient we just finished up has a herniated disc at C6-7. Made it a little bit difficult to get to, and why is that? Well, the reason is simple. If you look at the neck, the C6-7 disc sits right about here. Well, the collarbone is here, and the collarbone you cannot move. It's immobile. So basically, when I go in, I have to be above the collarbone enough I can get access to the disc. If the collarbone is blocking you, if the shoulders are a bit high on the patient, they got a short neck, as opposed to somebody with a long neck, you know, all those kind of anatomical variations affect the ability for the surgeon to get in and get the surgery done. Now, C6-7 is the lowest disc in the neck, and it's one that is probably the second most common to herniate and cause symptoms. So the one above it, C5-6, is the most common. But fortunately, with a lot of positioning and a great team that helped me in the OR, we were able to actually get into that C6-7 disc safely and get the surgery done. And it went really well. So during the surgery, you could see, are you going to show us a little bit of video? All right, so during the surgery, you could see in the beginning that I got the tube in the neck on the patient's right side. We quite literally lost just about half a milliliter of blood. And you can see on the video that's playing, we got the needle in, we're pulling the shoulders, trying to see the neck. The x-ray machine is there to the side. Once we got that needle in, we were then able to get the endoscope in, and then we're going down the endoscope here. You can actually see the laser at 12 o'clock. That is half a millimeter fiber, 0.5 millimeters. You imagine how small that is. It's just magnified by the camera. We have such a powerful camera that looks down that tube. And that metal stuff to the side, well, that's the tube. So we're sliding down the tube to the end, and right at the end, that's where the herniation is. Let's fast forward a little bit. You can see some of the pieces of herniation there. That's all part of the annular tear that I'm debriding and getting rid of the scar tissue in there, plus the herniated disc, so that it'll heal properly. And by doing that, we actually get it to heal properly after surgery in a painless manner. And that's about it. Let's go ahead and take a question.
Yeah. So can oral amino acid supplement help in filling annular tear gap
Tears.
in post-surgery recovery?
Yeah, it's a great question, because somebody's been paying attention. They remember in the last surgery I talked about how the annular tear heals, and it heals by forming collagen. Collagen is your body's natural healing protein, and the annulus itself is actually made out of collagen and elastin. And so when it tears and I clean it up with the laser, those torn edges can actually heal with collagen. So they're asking, well, what if we took collagen by mouth and ate it? Would that help us heal faster? The answer is, I don't know the answer to that, to be honest. I don't think anyone knows. But I will tell you this, the collagen that you eat is going to get broken down in your gut into individual amino acids. But those amino acids are then transported by membrane transporters across the gut lumen and into your bloodstream. So you will have protein available. I don't know that you really need to eat collagen to be able to heal your annulus faster, but I'll bet you if you eat a lot of protein with a variety of amino acids, that will probably be used by your body to heal that annulus faster. Really, to be quite honest with you though, the annulus's limited healing is primarily due to its poor blood supply. The annulus in that little outer wall of your disc doesn't get much blood flow. And things that get very little blood supply actually heal slower than tissues that get good blood flow. So I think that the slow healing of the annulus is more related to poor blood flow to the annulus, and there is really no way to improve that. However, the nutritional needs for healing are high, and so having amino acids in your diet, like protein supplements, is probably not a bad idea to help. The other thing that collagen requires in order to be made by your body is vitamin C. So I do recommend a lot of vitamin C, not overdoing it obviously, stay within the recommended daily doses, but you can go to the upper limits, probably 1 gram or 2 a day of vitamin C supplements. So that will help. Any other questions? All right, hope you enjoyed this. We have another single level cervical laser coming up in about 30 minutes. And then our last case for the day will be a bilateral L45 laser.